All right, coming to the next ECG, 42-year-old engineer male who comes in and is asymptomatic engineer, but gets his ECG done for an insurance. So what do you see on this? Insurance companies are always worried they don't want to give insurance to someone who is a sick guy, because then it becomes their medical liability to take care of all the medical bills. But if there is a pre-existing condition, they don't cover those for the future insurance. So P-wave, sinus rhythm, PR interval looks pretty normal, QRS is normal. But look at these large QRSs, very tall QRSs. So if you put criteria for LVH, AVL being more than 11, or adding V1, the S wave, and the R wave in V5 or V6, it does qualify to be diagnosed as left ventricular hypertrophy as such. So this actually patient, looking at the axis, the 1 is negative and AVF is positive, so there's a right excess deviation. So actually there's a young healthy guy, P waves are right in 2-3 AVF, and he has what a thin, lean gentleman normally has, a vertical heart right behind the sternum. And that sometimes gives a rise to these very tall QRS complexes. And actually, when he did his echo done, there was no real LVH, and it was just merely the physiological vertical heart that led to these kind of ECG changes and LVH pattern that are identified on the ECG. All right. Coming to the next ECG. So a little interesting ECG here. 62-year-old lady with bypass surgery, fatigued, lightheadedness, and now with exertional shortness of breath. So what do we see? What's going on? So the big complexes are the QRSs. And there is some different morphology in that, as you can see. So these are the P waves, and this is the pacing artifact. And this pacing artifact is many a times landing on like T wave here. Then it's landing on without any electrical activation. Over here, this got activated in the ventricle. And then there is a inappropriate P with no capture at all. So actually this female patient has sinus rhythm, atrial enlargement. These are ventricular escape beats which are coming up. This is the paced beat that you can see here with the pacing artifact denoted by this small artifact. Then there are P waves which are marching through. So this patient had third-degree AV block, total AV dissociation, and unfortunately had a pacemaker placed which is also malfunctioning. It is not sensing and it's not pacing appropriately. So that's why this patient is symptomatic. All right, so these are the diagnoses that you want to pick up when you're seeing an ECG like that. Right, so some of you are putting comments now, I see. And underlying third-degree AV block fixed, and there is a pacemaker which is not functioning well. Very good. So at least you guys can now put in comments. So everyone is fully free if you want to add any comment or so. And I think coming to the next ECG now. All right, this is a 76-year-old post-CVA female with sleepiness. Let's see what's going on with that patient. So what do we see here? The mode on that ECG was a DDD pacemaker with P waves. The atrial lead was the one which was not able to sense or pace. The ventricular one was pacing intermittently, but not sensing all of it. There are normally two modes of pacing that we see, BVI pacing or DDD pacing. BVI pacing actually does not have any clue about what is going on in the ventricle, in the atria. So it just has a timing period sense for an activity in the native ventricle. And if the ventricle, there is no native beat, then it gives the pacing artifact and captures the ventricle. All right, coming to this ECG. Now we're talking about 76-year-old post-CVA female with sleepiness. So what's going on here is a pretty straightforward, very similar case that we saw the last one. You can see the P wave here, no real correlation. AV dissociation with third-degree AV block. There is sinus rhythm. Atria is doing its part by giving an atrial kick, but it's just not being captured through the AV valve, the AV node. So that's why there is a ventricular escape rhythm, sinus rhythm. The QRS is a little bit wider. And these are your diagnoses in this. There is sinus rhythm, ventricular bradycardia as an escape rhythm, third-degree AV block, and complete AV dissociation. Yes, that is correct, what you have placed. All right, coming to this next ECG. 49-year-old smoker male with palpitation and lightheadedness. So right off the bat, this is a tachycardia rhythm strip. It's a wide complex, so it's most likely a VT. No real P waves that you can see. There might be small atrial activity, which is happening every third or fourth beat, but total AV dissociation. So this is a VT, ventricular tachycardia. So the way you deal with this kind of a patient with ECG is you check their blood pressure. And if there are signs of hemodynamic compromise, you have to shock them out of it. Otherwise, you can have time with a stable blood pressure. If it is more than 100 by 60, then you have time to play with lidocaine or amiodarone IV pushes, 150 or 300 milligrams. So that's how you treat. And the diagnosis in this is just going to be wide complex VT with the right axis deviation and complete AV dissociation. All right, coming to the next ECG. It's a 17-year-old mattress student planning to enroll into Army. So comes in to get an ECG done. So what do you see? It's a sinus rhythm. The rate seems appropriate. It's a narrow complex QRS. The PR interval is pretty. But what you can see is actually, if you look at the QRS carefully from V1, V2, V3, V4, V5, and V6, the complex is starting to get smaller because these are your reporters on the chest wall from V1 right in front to the V6, which is on the lateral side of the heart. And if your lateral side leads are telling you that they're seeing smaller and smaller electrical voltage, that means actually the electricity is going away from them. And that's why it is a right axis, and you can actually see that this is a dextrocardia in this patient. So normal sinus rhythm, P waves were there, right axis deviation, and the R wave amplitude diminishes across the precordial leads. So this is a dextrocardia. And in lead reversal, you don't normally see the one and V1 to V6 amplitude of QRS becoming smaller and smaller. All right, coming to the next one. 17-year-old passed out while playing basketball with his friends at school. So this is actually a true story. This young gentleman who came in and was brought in by friends from school, that he passed out. So they put some water on his face, gave some air, and he became all right within 5-7 minutes. But they still brought him for checkup. So the ECG was done, and the doctor in the emergency room said there is nothing concerning on the ECG, and he was sent back home. 2 days later, again, he was doing some athletic running at school, and he fell down and passed out again. And that is correct. The answer to that is the slurring that you are seeing over here with a short PR interval gives away the diagnosis of WPW, which is called Wolff-Parkinson-White syndrome. Yes. So short PR interval with a small slurring that we see many a times, that needs to be picked up, especially if somebody comes in with a diagnosis or a symptom of a syncope, loss of consciousness. This can be really dangerous. So we normally request our EP guys to do electrophysiological study and find that extra bundle, accessory pathway. And once that is zapped, then these kind of people do very well long term.